everybody. We thought we'd take this opportunity to really try to illustrate to you the difficulties in decision-making in ischemic heart disease that exist in 2016. A lot of people think that most of the problems have been sorted out, and we'd like to illustrate to you that they haven't. The format over here is going to be Colin and I will both be presenting some slides. I will introduce a few slides that gives you a background on the evidence that exists for surgical treatment of a group of patients with CAD. Colin will then present a few slides to you on trials that have supported the use of PCI and medical therapy for patients with CAD. And we hope to complete that in about 15 minutes tops, and then use the rest of the time to really have a case-based discussion with our panel over here, where we will present cases that we pulled from really patients that are on service right now or that have been treated in the recent past. We really don't have to go looking for patients that present complex decision-making problems, because they're all around us. So it's important to know, to those who don't know, that the first successful coronary bypass operation was done in this institution by Ed Garrett, Jimmy Howell, and Dr. DeBakey, all sadly passed on now. And this is from the original class slide of the patient showing. Roger, is there a pointer over here? It's not showing up on my thing. I was hoping to use the cursor. Oh, it's working there. And it's not easy to appreciate because the quality of angiography then was not as good as it is now. But this patient basically had a tight LAD lesion and ended up and had a saphenous vein bypass to the LAD. And you can just, with the eye of faith, appreciate the post-op angiogram showing the patent graft over here. So the evidence for CABG, really, the basis is in 3 large trials in the 70s and 80s, which compared CABG to medical therapy. Less than 10% of patients then received a Lima graft, and of course, medical therapy is not what it is today. These studies were the VA study, which basically showed that in patients with triple vessel disease and a poor left ventricle, CABG was superior to medical therapy, which of course at that time was basically nothing. The European coronary surgery study showed that patients with left main, triple vessel disease, or double vessel disease with a tight proximal LAD lesion also benefited from CABG over medical therapy. And the coronary artery surgery study showed that patients with triple vessel disease and ejection fractions that was somewhat depressed also benefited. A nice meta-analysis in 1994 updated this by looking at data from 7 randomized controlled trials that had been done since then, and basically confirmed those findings. Now, this is a slide that's difficult to read, but it's color-coded, and basically it's a timeline of trials in coronary artery disease. Now, on the top, you'll see on the left-hand side, it tells you about the events when the procedures originally came into being. 1964 was the first CABG, 1977 coronary angioplasty, and 1986 coronary stents. In blue on the top are trials that compared balloon angioplasty with coronary bypass surgery. Next to them in pink were trials that compared bare metal stenting with coronary bypass surgery, and most contemporaneously on the top in green are trials that compare drug-eluting stent versus CABG. On the bottom, all of the trials in yellow that are listed are trials that have compared revascularization, whether it's CABG or PCI, versus optimal medical therapy.
There's a couple trials that we as interventional cardiologists try to ignore or get over, to explain why they're flawed, explain the limitations, come up with entire thesis about why this should be thrown out. But despite our efforts, there is a real role, I think, and one that we don't deny and we all agree with, of optimal medical therapy. The reason being, Optimal medical therapy these days, or OMT, which will be easier for me to say, involves not just one or two interventions and not really just medicines. It's also lifestyle interventions that are very effective. And in Courage, which is summarized here, the findings now out to 7 years, these patients not only had medical therapy with statins, blood pressure control, blood glucose control, et cetera, but had very significant lifestyle interventions, smoking cessation, diet and exercise, optimal BMIs, et cetera. So when all those things are taken into account and executed as far as a intervention for coronary artery disease and vascular disease in general, people do very, very well. So I think we now all agree and have accepted that an initial approach as far as managing patients with stable coronary artery disease, optimal medical therapy is really probably the first line therapy. Now we'll review some cases where that can be a challenge when you have anatomic data in front of you. But when you're looking at a patient who has CAD, they're stable, medical therapy in addition to lifestyle interventions was just as good as an initial therapy of PCI with medical therapy. The other trial that sort of sheds some light on managing a more difficult patient population are those with diabetes. So this is the Freedom trial. And this was taking patients who had diabetes, at least 2 vessel disease, and in this trial there was no medical therapy arm. Everybody had baseline good medical therapy, and then they were randomized to an initial strategy of bypass surgery versus PCI with drug-eluting stents. So this is considered a more contemporary trial for coronary artery disease patients who had diabetes. And clearly the results here favored an initial strategy of bypass surgery over using PCI with drug-eluting stents, primarily reduce in myocardial infarction rates long-term and repeat revascularization rates. So we do frequently, though, every day in the cath lab, you'll see patients with diabetes who come in and end up getting PCI. So there's still room here for discussion, although I think up front we would all say and agree that an initial strategy of bypass surgery would be preferred, particularly in those who have very diffuse disease. The ongoing trial that's going to maybe shed some more light is somewhat controversial, depending on your belief of whether or not we have equipoise, but it seems we do have equipoise when it comes to stable coronary artery disease with ischemia, and that's the ischemia trial. So this is ongoing, should be, as far as we know, done by mid-2017. Patients with stable coronary artery disease who have moderate to severe ischemia on a non-invasive evaluation. That's the population. Those with kidney disease are taken out and put into a separate study, the ischemia CKD trial. But once you have this population identified, they all get CT angiograms. And based on their CT angiograms, they can be excluded for 2 reasons. 1, if they have significant left main disease, and 2, if they have no coronary disease. They had an abnormal stress test, but non-obstructive coronary artery disease or normal coronaries on their CTA, they're excluded. So they're really identifying people who have obstructive coronary artery disease and ischemia. Once you've identified that population, they're randomized to a conservative initial strategy, which will not include an angiogram. Everyone in Courage got a cath. These patients who go to the conservative arm will not get a cath, so there won't be the temptation there to potentially do some intervention. They will go for a cath, though, if they fail or they're not doing well on medical therapy, they're having progressive symptoms, et cetera. Versus the invasive arm in red, which all get an angiogram, and then based on their sort of local heart team's decision, they can either continue simple medical therapy or go for revascularization, and revascularization could be PCI or CABG, but they're all lumped into one group. So the conservative arm versus the invasive arm, and then it's a 3-year follow-up looking at stroke, death, and MI. So that will, I think, shed a lot of light on what our potential initial strategies will be for this very common patient population that we see. So I think we got that done in 15 minutes. So I'm going to start with the first case. And the panel here is Dr. Kleiman, Dr. Shah, Dr. Rule, and Dr. O'Hara will help us out as far as deciding what our options are, and the audience is also free, of course, to participate as well. The 79-year-old man with hypertension presented with chest pain and syncope. He did not have an MI, underwent a non-invasive evaluation with a stress echo. which showed global ischemia, and his EF during the echo went from 60 to 35%, and he had an ECG that had diffuse ST depressions. He had an angiogram, which shows a dominant left system with what appears to be some left main disease and then some diffuse non-obstructive disease in a high OM, some diffuse disease in the LAD. But the left main, starts to look more significant and is a little bit more consistent with the angiogram, with the non-invasive test. So we do an intravascular ultrasound to sort of better define this anatomy. And this is the distal left main. So what you're seeing in green here is the lumen. And in the blue here is the media, so the ideal lumen of the artery. So you see significant plaque burden here. To the degree that the minimal cross-sectional area of the left main is 4.3 millimeters squared, and a significant lesion is generally accepted to be less than or equal to 5.9 millimeters squared. But a percent stenosis of 85% by area, and with IVUS 60%, is generally the accepted. So I think we would all agree it's a significant lesion. It has inducible ischemia in a patient with symptoms. So now the question is to the panel and the audience, sort of how would you manage this patient? Medical therapy, of course, is initiated and optimized. Does the patient warrant revascularization, and if so, bypass surgery or PCI? Ross, what do you think?
B, number 2.
Okay.
This is the type of patient that I think warrants surgery and would really benefit from surgery in the long run.
You agree, Alpesh?
Not at all. So, I think we have now exciting trials and kind of shedding new light into this left main revascularization strategies. Obviously, I'm assuming the RCA is normal there.
Normal, non-dominant.
So we have started looking at left main disease in kind of new light, given some new data, and I'm sure Colin will talk about some of those trials. But I think left main stenting is a very viable option. Yes, this is a bifurcation lesion, and based upon that, we would assign what is called a syntax score. And syntax score, and then based upon those trials, we have seen that patients who have low to intermediate syntax scores, their event rates are very comparable at 30 days, 3 years, and so on and so forth. So I think left main stenting is a very acceptable strategy here, probably even a preferable strategy here. The only caveat, believe it or not, in this patient is that this patient will not meet the Excel criteria. You know why? Because we actually do not have a stent which is designed to size to a vessel more than 4.25. So that is kind of counterintuitive to what we would think, that this patient would have been excluded from our Excel trial. But that being said and done, I think now there is enough data to probably consider left main PCI in this patient.
Walter, Neil?
I'm sorry, I'm going to agree. Sir, I would go with surgery. And there's also there's a proximal LAD lesion there, too. You're going to stent that, too?
Yep. So the osteal-LAD is involved as well on the IVUS. So it's LAD and left main.
That's it.
Is the patient a good surgical candidate?
Very good.
So these are exactly the patients we enrolled in Excel trial, where there was a surgical and PCI equipoise, and LAD lesion is actually not, we basically tried to assign patients who had low or intermediate syntax score. And given that LAD lesion probably puts the syntax score to the low teens or high teens rather. So that will still be very acceptable.
Neil?
Are you going to talk about Excel?
Yeah, I'll show one slide of Excel.
So, yeah, so look, there's equipoise here still, I think. My leaning would be toward PCI. The left posterior descending lesion is a fairly straightforward lesion. It'd be easy to put a stent in that. And then, technically this left main's not very challenging. Alpesh is concerned about stent sizing, but, truthfully, in a vessel like this, if you went media to media, I think you'd really be over distending this. So if I had a 4.25 stent that were fully deployed, maybe even taken up to 4.5, and you confirmed it by IVUS, I'd be okay with it. The caveat is the data are for Zions stents. They may or may not hold for other stents, some of which can go a little bit larger, but I would lean toward PCI here.
Okay. And so that's
So
go
one
ahead,
more
Ross.
comment. We have at least 20-year data now on Lima to LAD that shows anywhere from 95 to 97% patency in angiographic follow-ups. I don't think we have any data that's that far out on drug-eluting stents yet. I think if you take this patient who, I don't have the entire history and physical, but I do know that given what the information we have, this patient would probably come out with an STS database operative mortality risk of about 0.5%.
Yeah, he's a low-risk, healthy guy. I mean,
He's very low risk, very healthy. I think he could get through coronary bypass very easily, would not be destined to require DAPT just to survive, and you take away the ticking time bomb of a drug-eluting stent at that point.
So let me ask each of the panel members, if it was you, Neil, what would you want?
PCI.
PCI. Alpesh?
Yeah, if I subject myself to an open chest, I run the risk of 2 times more bleeding complications, 4 times more transfusion, 8 times more arrhythmias, several kidney issues, and so on and so forth. And that's just a reality. And personally, I think in today's world, PCI is what I would prefer.
Ross, you want to operate on yourself?
I think my preference is clear.
Walter?
Yeah, I would have surgery. I'd have a Lima to LED.
All right, let me ask Howard Rubin in the back. Howard, what would you do? Hold on, we'd like you to speak into the mic because it's being recorded, and that way your comments will be captured.
Very much. One thing that came to mind when I thought about this patient is, what other morbidities does he have? For example, if he has back problems or hip problems that might require him to have surgery in the future, that would require him to come off antiplatelet regimen, which would subject him to increased risk of thrombosis at any time. I think that needs to go into the formula of our thinking. It's not uncommon, as all of us as cardiologists have known, that we have patients who come in and 6 months out after they have their stent put in, we get a phone call that somebody needs to have some sort of procedure done, and we have to withdraw the dual antiplatelet therapy. The other question, and in regard to this also, is that we, as part of the ACU, we also need to determine before we do PCI that this patient actually will be taking the dual antiplatelet therapy. Is he reliable? He's been reliable in the past. Will he be reliable in the future? I really think that needs to go in the formula. If the answer to one of those 2 questions is that no, he's not a good, yes, he might have something in the future, or B, that he's not been reliable in the past, then I would lean towards the bypass surgery.
Those are excellent points, and I just want to point out this case was from 2012, so I'll give you some follow-up in a minute here. But he's very reliable, educated, bright guy who's going to take medicines. For the time being, there's no foreseeable intervention, but he is in the age where he may end up needing some sort of intervention. And along those lines, Dr. Rubin, it's not uncommon, as you know, we put them on dual antiplatelet therapy, and then suddenly they come in with a GI bleed, and then we unmask something. So there are risks here to putting a stent in, because there is also a pharmacologic therapy that goes along with it. So fast forward to last week. This was the Excel trial summary slide presented by Greg Stone at TCT. So Excel was taking patients like this with isolated left main disease, being evaluated by a heart team, as we have here and in this room, and deciding if this patient would be a good PCI candidate and a good CABG candidate. And if the answers to both of those questions was yes, then they would get randomized to initial strategy of PCI versus bypass surgery. And what you see here is the outcomes to 3 years with stroke, death, and MI. The PCI group is kind of in the orange here, and the CABG group in the blue. And at 3 years, they met their endpoint, which was non-inferiority for PCI as opposed to initial strategy of bypass surgery. Compare that to what was presented 15 minutes later at TCT was the Noble study. So Excel was a US study that we participated in. Alpesh was our PI. And the Noble study is a European version of studying isolated left main patients with initial strategy of CABG versus PCI. Very different result. Here you see event rates in red for PCI out to 5 years at 28% versus CABG to 5 years at 19%. And PCI did not show non-inferiority, and CABG was deemed in this trial to be superior to PCI. So what do? There are some, without getting too granular, there are some differences in the two trials. The two main ones, there were different definitions of MI, but I think the other main difference in endpoints is Excel did not include repeat revascularization, and Nobel did include repeat revascularization as an endpoint. And so that may have driven some of the differences in these two outcomes with a similar patient population. Our patient did get enrolled in Excel here, and we randomized him to PCI. He got a stent, just one stent in his left main into his LAD, and he did fine. And he did come back just this past spring needing to be pre-opt for hip surgery. But we had already actually taken him off dual antiplatelet therapy. He was on aspirin alone. He got recathed, the stent looked fine, and he got his surgery fairly uneventfully. So that's where we stand today with left main disease.
Two trials that you just mentioned that are hot off the press.
Yeah.
The major difference, at least looking at the data casually, is the early event rate. Because if you look after that, the slopes are diverging gradually in the same direction. So in the Excel, early event rate was much higher with the CABG. And the question is, why? Is it just because of endpoints, et cetera?
Yeah.
And I think that's the major issue really here.
It is, and there's a good chance actually that, you know, with time, CABG will actually overcome PCI, because if you look at the curves, they're actually meeting, and then it's not uncommon where later we'll see actually a divergence of the curves with time. But you know, that remains to be seen. I think as an initial strategy, you know, they met their endpoint of non-inferiority, and so I think you know, I think it will change guidelines. You know, right now it's a 2B to do PCI on the left main, whereas now I think it'd be more reasonable to have it as an acceptable, if not preferred, in certain patient populations based on this data.
So, two contemporary trials, literally from last week, that have got conflicting results, illustrating that, you know, we think we know something.
Wait, hold on.
I'm sorry?
The results aren't conflicting.
Oh, okay.
The results are different.
Different.
That's not the
Great.
same as conflicting.
Yes,
And the reason
different,
is,
yeah. So,
Noble
but-
was,
Yes. Yeah,
Noble
no-
is a smaller trial, different stent that may or may not have something to do with it. As a smaller trial, you need more components of an endpoint. So they included revascularization, which is not a catastrophic event. Excel was a larger trial. Their endpoint consisted of catastrophic events, death, MI, or stroke. If you looked at Noble, at death, MI, or stroke, the rates were identical.
They're the same, yeah.
So different, but not conflicting.
Well, no discussion in the contemporary era of the treatment of coronary artery disease would be complete without talking about the Syntax trial. This was a randomized controlled trial, the 5-year results of which were reported in 2013, a randomized controlled trial of drug-eluting stents versus CABG. 85 centers in Europe and the US, all comers to mimic the real-world situation. And as a reflection of that, when you look at the numbers, almost 4,500 patients were screened, and a whopping 71% of these patients were enrolled, which is absolutely astonishing. I don't know that there's any other trial of this magnitude that has achieved that kind of enrollment rate. 58% of those enrolled were randomized equally, and the remainder were placed into a registry, most of whom were deemed too complex for PCI. All patients were screened by a heart team, and this was the first time that a concept of the heart team really came came to the fore. When the trial was designed several years prior to this, the heart team concept was central to the execution of the trial. They had a composite endpoint of death, stroke, MI, and repeat revascularization. And I think one of the major contributions that the syntax study did was to introduce the concept of a syntax score to assess the complexity of coronary artery disease. This is a diagram, the diagram that was used to score the complexity of coronary artery disease. And basically, you added numerically to the score based on the number of lesions, the complexity of lesions, and where the lesions were located. And to put it another way, there is 3-vessel disease and there is 3-vessel disease. So if you look in the in this upper area here, you've got a patient who's got a relatively low syntax score, and here you've got a patient who's got a high syntax score because of multiple lesions of greater complexity. And they broke down the outcomes in the trial based on patients, well, the entire cohort of patients, and they also looked at outcomes in low, intermediate, and high syntax score patients. The overall outcomes indicated that at 5 years, Cabbage was superior to PCI. But when you looked at the low score patients with a syntax score less than 22, there really wasn't a significant difference, or not as much of a difference. When you looked at high scores, there was a much greater difference between Cabbage and PCI. The summary was that the 5-year results demonstrate that surgery remains the gold standard for patients with complex multi-vessel disease. But in patients with less complex disease, not properly defined because subgroup analyses are fraught with, with issues, but it certainly indicated that PCI may be an acceptable alternative treatment. One of the strong recommendations that was made was that treatment decisions for patients should be made by a heart team, something which is still not done most commonly today. So why is Cabbage better than PCI in patients with a high syntax score with complex disease? Well, PCI treats an isolated lesion in the proximal vessel. The complexity of the lesion affects the outcome. Cabbage bypasses the proximal 2/3 of the vessel, where the current threatening lesion and future threatening lesions occur. This is in patients with complex disease that have got multiple lesions. The complexity of the lesion is irrelevant because you're not messing with the lesion, you're going around it. And this advantage of Cabbage will persist even if stent restenosis is 0. So I think we'll dive into a case, Colin. Got a patient over here to talk about. This lady is a 39-year-old woman who presented with shortness of breath and chest heaviness in late September. She was at work. She works for a software company in North Houston. No previous episodes. She has a history of gestational diabetes in 2003, but that was it. She was admitted to Tomball Hospital with a diagnosis of pneumonia. She was found to have a hemoglobin of 8.1 with an iron deficiency pattern, no history of GI bleeding. She does report heavy menses for several years. She is a Jehovah's Witness. Her hemoglobin A1C was 12.8. Troponin was 2.4, and so they took her to the lab and did a cardiac cath on her. Ventricular function was normal, and the right coronary artery had no proximal or mid disease, but diffuse disease in the PDA that you can see. Most concerning was what they found on the left side. So I'd ask the panel now, what would you do? Let's start with you, Neil.
And remind me of the presentation.
shortness of breath and chest heaviness.
And non-STEMI.
Non-STEMI. 39, Jehovah's Witness,
So
anemic.
she's 39, she won't take blood. She's got hemoglobin of 8.1. That's going to be an issue for you. It's going to be an issue for us. I think the first thing you have to do is try to settle her down and get that anemia worked up fast. You've got to know, is this menses alone, yes or no? Is there something else that's not going to be easy to manage?
So she's had a GI workup, and all that's negative. They really can't find any reason for her being anemic other than the history that she reports of heavy menses, which, you know, is a...
Yeah, so management of that includes hormonal therapy, which is always kind of concerning because it's prothrombotic often, not necessarily, but often. I think if you can get her hemoglobin up with an erythropoietin analog, I would do that and then drop a mammary into the midsection of the LAD.
Sorry, could you speak a little louder, Neil?
It was so painful to say that I cannot repeat it.
I'd just like to hear what you had to say there. What was that last thing you said? Get her hemoglobin up and
Put a stent in the...
put a stent in the...
posterior descending. No, I would get the hemoglobin up and then, you know, she's 39, I think I would drop a mammary into the mid-LAD.
Yeah,
But you got to get the hemoglobin up first.
yeah. He was genuinely having difficulty saying that, and I will tell you, another word that Neil has a great deal of difficulty saying is courage, which was the trial that showed that optimal medical therapy is often better than PCI for treating patients with coronary disease. Alpesh.
Well, look, this is a challenging case. No matter what treatment arm you choose. You know, it seems like intuitively if you do bypass surgery, avoid DAP, this patient will do better. It is not that simple. I mean, this patient is an end-stage renal disease patient with underlying anemia. These are high surgical risk patients to begin with. That being said and done, a rush to a PCI would be poor judgment in this patient. I would personally, as Dr. Kleiman said, figure out the cause of anemia, the root cause of anemia, treat the anemia to the best of our possible options, and then put this patient on a DAP therapy for 1 month. See what happens to her clinical scenario. Does she bleed? Does she not bleed? Get a sense of the compliance. And then restudy her. I don't think, and again, I'm going out on the limb, but I think delaying a therapeutic option here, if available, is not a bad choice. Just to go back on the Syntex and Excel, I just want to make one comment. We keep on talking about those trials, but remember, stent technology has advanced a lot. And Syntex is a trial of the past. We don't use those stents anymore.
I agree with you, Alpesh. Now, when you restudy her, would you do a non-invasive, or how in a month? What would you do? I was thinking the same thing: medical therapy and then stress in a month.
Yeah,
Probably.
I think that's a very fair, good option. Again, I think trying to rush into any invasive strategy is fraught of. We're going to end up in trouble in many different ways. I think a non-invasive imaging is fine, or if you can really establish compliance and no bleeding risk in spite of 1 month of DAPT, a stenting is a good option on this patient.
Yeah, because the non-STEMI could
Hold on, I'd
partially
like
be
Walter to
hemoglobin.
comment. Walter, what do you think?
All right, so you need to cool this patient down. She's 39 years old, so the chances of something else happening probably pretty high, I would say, if you stented or did heart surgery. But I would get this lady ready for heart surgery, for CABG. Get her diabetes under control. You may need, you could do 2 mammaries on pump after she was worked up for her anemia. And also I want to know about any Von Willebrand's or any problems with the cascade there prior to surgery. Get her hemoglobin up, talk to her about blood transfusion and not using it. But I would offer heart surgery, CABG for this, for long-term benefit. I think all these studies we're looking at 5 years, CABG does better. I mean, she's 37 years old. I mean, she's going to require a CABG at some point in her life, I think.
Neil.
Yeah, we're all talking about cooling her down. We need a little more, and we have risk scores now to tell us how successful you're likely to be cooling her down. If you think about the therapies that are disease modifying in a patient who's presented with a non-STEMI, there are very few. There's dual antiplatelet therapy. It's been demonstrated to be disease modifying, changes your risk of having an MI or dying. And there's revascularization. Beyond that, you can give them all the beta blockers you want. There's nothing to tell you that that changes her outlook one iota. You can give her all the nitrates in the world. You can give her, as much ranolazine as she can afford. That's like excreting upwind.
So she was transferred here, chest pain-free, normal chest x-ray, seen by hematology, confirmed that she had an iron deficiency anemia, guaiac-negative stools. She was started on those medications, discharged, and she's been seen every week by the hematologists over here with a blood draw, with a pediatric tube. And so that's been going on for a few weeks, and our plan is when her hemoglobin gets to at least 10, is to operate on her. Here's an interesting one. This is a 58-year-old gentleman who presented to Methodist West on the 26th of October, just a few days ago. No prior personal or family cardiac history. Type 2 diabetes for 5 years, non-smoker, no alcohol. The only past history is that at the age of 25, he had an episode of jaundice and he was told he had hepatitis. He doesn't know what kind, but he's been okay since. Married, 2 kids, works in a grocery store. His ECG was concerning for a STEMI, not totally clear-cut, but concerning for it. The troponin was greater than 30, and he was taken urgently to the cath lab at Methodist West Houston. On the left, you see that he has what looks to be a flush occlusion of the LAD at its takeoff. I can get the cursor to work. Yeah, right there. And he's got some disease in the circumflex system that you see out here and over there. The right coronary artery, as you see in the right-hand frame, is not disease-free, but the disease burden is largely located distally. An attempt was made to cross the LAD lesion, the LAD occlusion, and they were unsuccessful. His left ventriculogram showed that he had extremely poor left ventricular function, and by echo, it was shown to be less than 20%. An intra-aortic balloon pump was placed, which you see in the right-hand frame, and the patient was sent here. So he arrived on Thursday, the 27th of October. He was not intubated. He was lying flat, had an intra-aortic balloon pump. His chest x-ray showed that he had mild pulmonary edema. Normal sinus rhythm with decent hemodynamics. He's making urine. Creatinine is not normal, but not bad. Echo showed an EF of less than 20%. And importantly, the anterior and the lateral LV were thinned out. He had only mild MR. A CT angiogram done the following day to assess the LAD to see whether there was something there that was bypassable showed that he had a heavily calcified LAD with occlusion along most of its length. EF was estimated at less than 20%, and again, the anterior and lateral walls of the left ventricle were very thin with a possible inferolateral diverticulum. So, Neil, what would you do now?
I got one word.
Huh?
One word.
One word.
Ready?
Yeah.
Arvind.
Arvind.
I think you
So
got a
tell us
thin
why.
wall.
Walk us through that, because it seems obvious to us, but
Yeah, I think, you've got a guy who has recently had something. His EF has become terrible. All our relatively low-key indicators of benefit for revascularization are absent. I think they've made what I think's a pretty conservative attempt to revascularize the LAD without success. Based on the CT reading, there probably isn't much you'll be able to do for it, although Alpesh will argue with me. The wall's thin.
Well, I did ask Alpesh to see the patient, and
Well, he'll get his chance.
and he
I don't think that this is an ischemic heart disease case anymore.
You mean a case for revascularization?
Yeah, or
Yeah.
other management of IHD. I think, the heart failure crew is going to help this guy more than we are.
Yeah. This is just to demonstrate to you the variety of ways in which ischemic heart disease can present and how important it is for us to engage colleagues really from all disciplines in the management of these patients that are very complex. Alpesh, what do you have to say about this?
Well, I also have one word, which is Irwin. But the simple
Well, you
fact
didn't say
is,
that in the beginning. You said you were going to try to cross the LAD occlusion.
so let's go back to that.
Yeah.
Why? If somebody has completed a STEMI and presents to you after 12 hours, this is the time we receive this patient, and if there is evidence of ongoing ischemia, there may be a benefit of revascularization, especially when the attempts at revascularization looked so feeble. However, if there is no evidence of ongoing ischemia, there is probably zero benefit at this point. With the concern of possible ongoing chest pain, you can make an argument in a timely manner to possibly consider revascularization with better techniques, better operators, so on and so forth. Nonetheless, once it has been established that there is no evidence of ongoing ischemia, zero benefit.
What do the surgeons think?
I personally don't think revascularizing his LAD territory or circumflex territory for that matter is going to make him better. And I think that he is a patient that would be better served by working him up for transplant possibilities.
On Friday, yes.
How about if on the CT angiogram, you had a decent distal LAD vessel? I would not stop there if that was the case. And the reason for it is you mentioned a few things regarding viability that are important. One is that the troponin was not too high, just 30, for the degree of dysfunction that this ventricle has. That's number one. Now, you don't know whether he's had events before and this is just another event that he had. Then I would do a cardiac MRI to look at how much viability does he still have. If all this area of dysfunction that you see is really scarred out, then you have a complete case of non-viability, and I would call Arvind and his team. But I think if he had a revascularizable LAD, I would pursue it further.
So
agree
let
with
me
you.
bring back something, a very painful memory for Dr. Barker. It's called the OAT trial. And this was a big NIH-funded trial done a few years ago, looking at patients who had an MI between 3 and 30 days, actually, who were found to have a totally occluded vessel between 3 and 30 days after myocardial infarction. They were randomized to revascularization versus not. The bottom line is the outcomes were no different based on revascularization. There was a sub-study called TOSCA that looked at those patients within that trial who had evidence of ischemia on a scintigram. And so if you had ischemia and a totally occluded vessel, there was no difference based on whether you were revascularized or not. So I would say in this situation, the case for revascularizing the guy is really thin. And Colin participated in that trial.
So let us consider the scenario that Bill pointed
Well,
out.
let Colin tell you.
Well, I think,
correct me.
no, you're exactly right. But I also, the other memory I'm having on this case is the shock trial. I mean, you could argue she has a balloon pump, or he, so there is some component of shock there, which would warrant early revascularization. And I'm just the surgeons, 20 years ago, wouldn't you have just operated on this guy? I mean, this is acute MI, he's got an LAD. I mean,
Yeah, as a 58-year-old man, it seems to be the first logical step in the progression of therapies that you would give him. But let's just take the scenario that Bill pointed out, and we have another case like that. We won't have time to present it. Suppose the CT angiogram showed that he had a big, juicy LAD, but the anterior wall is completely thinned out. You don't have a mechanism to do an MRI because he's got a balloon pump in place. What are you going to do?
May I interject one thing which is really very important, and you need to know this data. These data came from here, from multiple and other collaboration institutions. A thinned out heart, just like you're seeing here, I know we haven't seen it, doesn't necessarily exclude significant viability. And actually, it was Dr. Deepan Shah, published in JAMA a few years ago, that if you had viability and you revascularize, you have reverse remodeling and rethickening of that particular wall. So yes, in the past you used to think if there was only thinning, yes, the likelihood of viability is low, but particularly in an individual like this, you really have to look at viability if you have a revascularizable area.
So let's look at the other side of that coin.
Yeah.
You have a very nice study using modern technology that shows you make the pictures better. We have a randomized clinical trial that shows that you don't make the patients better.
There is individuality, and there is a trial. You have to think about an individual patient's presentation and put it in the context of a trial.
Well, understood, but, you know, the patients in OAT, first of all, I take that back. I would be very suspicious if they randomized patients who had lousy distal vessels.
The thing that tipped the decision here for me was the fact that the LAD did not present, a target that could be revascularized either by surgery or by PCI. There wasn't much to be gained over there. However, I will say that if the CTA had shown that there was a nice LAD target, I would have pushed for revascularization either by asking Alpesh to try open up the CTO, or personally I would have operated on him.
Remember, the road to hell is paved with good intentions.
Yeah.
Arvind's got a quick point.
Yeah, to give a voice to the one word they asked for. I do want to stress the fact what Dr. Zogby added. Even with the balloon pump, what we had done before is to use a thallium viability, because you can't get an MRI if they need a balloon pump. But I think if there is viability, we can have a backup plan of mechanical support and transplant and all those things. But I would still push for some kind of revascularization with the risk-benefit discussion. And then if none of those are an option, I mean, you would go down the path of medical optimization while we plan for the future for that.
Yeah. I mean, I think if there's a target in the LAD, that's a very reasonable thing. But if you've got nothing to work with, you've got nothing.
Just for that point quickly, for Faisal or Sumin, how confident are you on determining whether or not a lesion's revascularizable based on a CT? I mean, that's a pretty big call. And as far as I know, it's not been done.
So, I think we have the same limitations like in the cath lab. You have to perfuse the RD to be able to see it. But I think, if we know a priori that that's what you're looking for, we will definitely make our best attempts to get, reasonable interpretable images. And that may mean that, even after the first perfusion scan, we may repeat, and rescan the patient one more time, allowing contrast to get deeper into the, past that blockage, and hopefully trying to pacify the vessel.
Mahesh,
We can at least try to make an effort.
Mm-hmm.
We can do it with nitrates, yeah.
The key is probably to order it in that way, so do all those extra things to try to increase the sensitivity, right?
Yeah, absolutely. I mean, the more we know about the patient beforehand, we can definitely try to optimize the study.
So if it's well perfused, you see it better and it looks juicier. But then it's well perfused, how much are you adding? Remember, you get nicer pictures, we don't get nicer patients.
I have an example of that exact patient that if you want to hit that white button, I can give it in 1 minute. or
Yeah,
less.
we'll
Let me
finish
just,
this
let me
one
just
up
ask
right
one
away.
question, though. So you're thinking that this chronically occluded, that doesn't have any flow in it, is causing a troponin of 30, and it's thin-walled ventricle. So this didn't happen yesterday or whatever.
Yeah, I don't think
This has
that's
been
what it
going
was.
on. It's probably a diagonal that went down, or it's that circ. I mean,
Yeah.
that's, right?
Yeah.
It's not this.
But
So
I
you
think-
wouldn't treat this. This isn't the acute problem. That's
Right.
what I think, just
I
looking at
agree,
this
but I
scenario.
think in this patient, he doesn't have a target to revascularize, so we have to look at other options. Anyway, the following day, Friday in the evening, ventricular fibrillation, a single shock, and he was intubated. 3 further episodes over the weekend, each terminated quickly with a shock. Heart failure was consulted, and on Friday, the 4th of November, last week, he had a right axillary impeller placed so that the balloon could be removed from his groin as a temporizing measure. Now, the patient is uninsured. So as we speak, this 58-year-old gentleman lies up in the Fondren ICU with an axillary impeller, waiting for, Arvind, what?
Charity care.
I'm not directly involved, but I think we're trying to figure out options.
Maybe Ash knows.
Figure out options, I think, where we are.
Well, what are the options? I mean, what are the options?
I mean, I think it's also complicated by the fact that I guess he has an aneurysm at the apex, right?
Of course he does.
No, that's not. Yeah,
Maybe. Everything's maybe.
He will. But
Yeah, he will.
in general,
Early.
this is a bad situation to be in. But I think
Well put.
and from the context of if he's, I think we've reached a point where we've crossed the line that he can survive with his own heart. That's where we are. Options of mechanical circulatory support are probably his only choice, and how we figure out financially, is what we're stuck with.
So what financial, I mean, what are the options? Is he going to get coverage? Is he going to get Medicaid? Is he going to get magic, financial magic?
Yeah, I think we are exploring with the hospital to see if there can be some hospital support for a durable device, but
Yeah.
that's where we stand. But of course, his main, his issue is also complicated with recurrent VT. I think that's been a big issue, and every time we try to even wake him up a little, he goes into VT despite being on IV antiarrhythmics, and that's been another issue.
So, Mahesh, do you think he's still ischemic, you're thinking? From, what's the VT cause for him?
Oh, he has an irritable myocardium. I mean, there's all sorts of
Can I add
scar.
a little bit more complexity?
Yeah.
Yeah, so you just,
It's not VF. It's been VT. It's regular monomorphic VT. This is a substrate, mature scar. This is nothing acute. This is not the arrhythmias you get with acute ischemia. He's got a mature scar and has a substrate for VT that's probably a scar-related VT reentry, and it's limiting our options now because every time he wakes up, he goes into VT. So the team is pushing for him to get a VT ablation, which is basically for him to die under my procedure. No complications, and not, it's not going to change the big picture. So we're trying to hang tight until we get a clear picture as to what we can do as far as definitive therapy. The VT ablation would not be definitive therapy. So we'll see.
So we've presented 3 cases to you. One was a left main, relatively straightforward, so it seemed. Another was a young woman with triple vessel disease, relatively simple, or so it seemed, decision making. And finally, a patient who really is at the utmost extreme of ischemic heart disease, which I think beautifully illustrated by the discussion we had in the audience, how many people were involved and continue to be involved, meaning folks of different disciplines continue to be involved in the care of this patient, and how crucial it is for this patient that they remain involved, because the decision-making is driven by not just one person. And I think that a multidisciplinary approach to coronary artery disease is the future. Ischemic heart disease is like cancer. It's not one disease, it's many diseases with a very broad spectrum, many treatment possibilities, often in the same patient. And the best decision-making can be difficult to do. We're making decisions based on imperfect knowledge, but decisions have to be made. And I think having a team approach helps with that. It's about patients, not procedures, convergence of best medical therapy, PCI and CAB. The syntax score, I think, was a major contribution. The role of hybrid procedures, where you combine CABG and PCI, is as yet undefined, and there is a major national trial about to start, of which we are one of the participants. And the heart team approach is essential for optimum care. And this is a sort of a Venn diagram showing how different people can be involved in the decision-making for an individual patient. Now, another reason why it's important is because starting in 2017, Medicare is going to introduce value-based purchasing. This means that they will pay hospitals and providers, doctors like us, a single lump sum, not separated into what the hospital gets paid and the physician gets paid. The two of them combined get a single lump sum for episodic care. And that means that everything that happens to that patient during the hospitalization and subsequently for the first 90 days is paid for with a single amount. They have picked 3 DRGs for this, and one of them is hip replacement, one of them is CABG. So good decision-making is going to be important, not just for the patient, but for the bottom line.
Great, thank you. One more comment here.
I just have a comment. What you just said about the complexity of coronary disease is really so very true, and the coming payment schedules for the disease is going to be really important, because a heart team concept, I think, makes a good deal of sense. I want to emphasize the value of an intervention, whether it be coronary bypass or PCI. We know long-term more about coronary bypass than we do PCI. But I've had the good fortune to work in this hospital now 48 years, with coronary bypass began in the late 1960s. And it's amazing how many people I have followed for between 20 and 40 years who've had coronary bypass surgery and then good medical therapy, who die of something other than coronary disease. Coronary disease can be something that can be managed forever and ever in many patients, and let them die of an automobile accident or a fall or something else. So the appropriate approach to particularly the complex problems you've discussed today, through a combination of number of people looking at them and a heart team, I think is really an important step forward.
Great. Thank you. And so with that, we'll finish.